Let's review safety and infection control. And we'll start off with part of standard precautions. One of them will be the environmental control. So again, you want to remember, don't recap used sharps or bend or break or remove used needles. You don't want to manipulate used needles with two hands. So use a one-handed scoop technique. And you want to place used sharps in a puncture-resistant container. When we are resuscitating patients, we want to use a mouthpiece, we want to use a resuscitation bag or other devices for mouth-to-mouth resuscitation. General rules for client placement would include a private room. If the client has poor hygiene habits or he contaminates the environment or he can't assist in maintaining infection control precautions, for example, like infants or children or patients with altered mental status. You also want to remember that when you are sharing or when we are cohorting or sharing rooms, you want to consider the epidemiology and mode of transmission of the infecting organism. And general rules with transport would include using barriers when you are transporting your patient, like a mask or an impervious dressing. We also want to notify personnel of impending arrival and precautions that will be needed. You also want to inform the client of ways to assist in prevention of transmission. So we remember that standard precaution is used with all clients. It's a primary strategy for infection control in all settings. It's the most important way to reduce transmission of pathogens. And it applies to contact with blood, body fluids, non-intact skin, and mucous membranes from all clients. And one standard precaution would be hand washing. Hand washing should be done immediately on contact with blood or bodily fluids. You want to wash your hands before putting on or taking off gloves. You want to wash your hand between client contacts and even between procedures or even attacks with the same client. You want to wash your hand in between attacks with the same clients or immediately after exposure to blood or bodily fluids. Gloves are also part of our standard precaution, and you want to use clean, non-sterile gloves when you are touching blood or body fluids or secretions or excretions or even contaminated articles. We want to put on clean gloves just before touching mucous membranes or non-intact skin. So you want to put on clean gloves just before touching mucous membranes or non-intact skin, or when we're going to touch blood or body fluids or secretions or contaminated items. So we want to put on clean gloves. Again, we want to change gloves between tasks and procedures. We also want to remove our gloves promptly after use. We want to remove our gloves before touching items and environmental surfaces. Your masks, eye protection, face shields, these are all part of our personal protective equipment, and they are used to protect mucous membranes, like the eyes, the nose, the mouth, during procedures and client care activities that are likely to generate splashes or sprays of blood or bodily fluid or excretions. So again, we use them during client care activities that are likely to generate splashes or sprays of blood or body fluids. Gowns also form part of our personal protective equipment, and we want to use clean, non-sterile gowns to protect the skin and prevent soiling of clothing during procedures and even client care activities that are likely to generate splashes. And it should be removed promptly, and you want to wash your hands after leaving the client's environment. So again, these are part of our standard precautions: hand hygiene, use of our personal protective equipment like our gloves, gowns, masks, eye protection, and face shields. So those are your standard precautions. With airborne precaution is used with pathogens that are smaller than 5 microns. Because of their size, they can be transmitted by the airborne route. So these are droplets or dust particles that can also remain suspended in the air. Part of our airborne precaution would be to place the client in a private room with monitored negative air pressure that has 6 to 12 air changes per hour. So again, airborne precaution would include negative air pressure room, a private room with 6 to 12 air changes per hour. Negative airflow pulls air from the hospital environment into the room, and the air from the hospital room then goes directly to the outside rather than recirculating to the rest of the hospital. That's what we mean by negative air pressure. We would also want to keep the door closed. So again, with airborne precaution, you want to keep the door closed and client in the room. And susceptible persons should not enter the room. Or if they are going to enter the room, they should wear an N95 HEPA filter. We can cohort or place clients with another client, but again, both of them must have the same organism. We also want to place marks on the client if he's being transported. So the healthcare provider who transports the client would wear an N95 respirator mask as protection against the exposure to airborne droplets. What are examples of diseases in this category? I remember them with my MTV. Remember the music channel MTV. Again, MTV is in the airwaves. It's in the radio. It's in the radio. So I just use that to remember those diseases that are airborne. So MTV, where M would be your measles, T would be TB, tuberculosis, and V would be our varicella or chickenpox. So M would be measles or rubella, T would be tuberculosis, V would be varicella. Again, remember, we're going to place them in a private room with negative air pressure with 6 to 12 air changes per hour. We want to put a mask on the client if we are transporting him, and the healthcare provider is going to wear an N95 mask, especially for tuberculosis. With droplet precaution, so again, you want to remember Spider-Man dropping from the roof. That was an iconic scene in the movie. So that's Spider-Man dropping from the roof, droplets. Okay, so with droplet precaution, it's used with pathogens that are transmitted by infectious droplets, droplets that are larger than 5 microns. And it involves contact of the conjunctiva or the mucous membranes of the nose or the mouth. Transmission happens during coughing, sneezing, talking, or during procedures like maybe when you are suctioning the patient or during bronchoscopy. So with clients with droplet precaution, we're going to place them in a private room or with clients with the same infection. So we're going to wear masks if we're in close contact with this client. We're also going to maintain a spatial separation of 3 feet between infected clients and visitors or other clients. So again, remember with droplet precaution, you want to maintain that 3 feet distance between clients and other clients or visitors. Because we said these droplets are more than 5 microns, they can remain suspended in the air for long, so the door may remain open. We'll need to place marks on the client if it's being transported. And what are examples of diseases in this category? So I use Spider-Man to remember those diseases. Remember we said Spider-Man is dropping from the roof. So that's droplets. So that reminds me of droplet precaution. And if I spell out Spider-Man, so some diseases in this category would be S for sepsis, scarlet fever, streptococcal pharyngitis, P for pneumonia, which is the most common, pertussis or parvovirus. I would be influenza, so you're going to see influenza, Haemophilus influenza. D would be diphtheria. E would be epiglottitis. R would be rubella. M would be for your mumps. Another common one would be meningitis, mycoplasma, meningeal pneumonia, and AN would be adenovirus. So again, Spider-Man reminds me, when I remember Spider-Man dropping from the roof, I think about Droplets Precaution, and then S, and I spell it out to have all of those disease conditions that are in that category. With contact precaution, we know contact precaution is needed with client care activities that require physical skin-to-skin contact. For example, when you are bathing your patient or you are turning the patient, you will require contact precaution. Or even when you're going to be in contact with contaminated inanimate objects in the client's room. So again, with contact precaution, we want to put on clean, non-sterile gloves. If we're going to be in contact with the client or contact with potentially contaminated areas. And you want to remember to change your gloves after client contact with fecal material or maybe wound drainage. So you will need to change your gloves. We want to remove our gloves before leaving the client's environment. And then you want to wash your hands with antimicrobial agents. We also want to wear a gown when entering the room. If our clothing is going to come in contact with the client or environmental surfaces, or if the client is incontinent, maybe has diarrhea or ileostomy or a colostomy, or maybe has a wound drainage, then we'll need to put on our gown. Remember, you want to remove your personal protective equipment like your gown before leaving the room. We already said you will need to remove your gloves before leaving the room. So again, you want to remove your PPE before leaving the room. And we'll need to use dedicated equipment for these patients who are in contact precaution, or we'll need to clean and disinfect the equipment between client use. Again, how do I remember those disease conditions that will require contact precaution? I remember Mrs. Wee. I don't want to be in contact with Wee, so I remember Mrs. Wee. So if I spell out Mrs. Wee, M would be for our MRSA. That would be your multi-drug resistant organisms like your MRSA and our vancomycin resistant organism. So that would be for M. R would be our respiratory infection like your respiratory syncytial virus. S would be for skin infections like our herpes simplex, like your herpes zoster or scabies or pediculosis. So those would be your skin infections that will be requiring contact precaution. W would be for wound infections. E would be for enteric, like your Clostridium difficile, or even your rotavirus. And E would be for eye infection, like your conjunctivitis. So again, those are disease conditions for contact precaution. Let's look at Lyme disease. Lyme disease will be a multi-system infection that is transmitted to humans from a tick bite, and it's most common in summer months. Okay, so when a tick bites a human, Lyme disease can be transmitted. And what are you going to see? So the symptoms are going to appear in different stages. And in stage 1, we're going to see a rash that develops at the site of the tick bite within 2 to 30 days. And then these concentric rings is going to develop. So we'll have these concentric rings that suggests a bull's eye. So that's going to tell you my client may have been bitten by a tick. So again, the rash is going to develop within 2 to 30 days, and then we begin to see these concentric rings develop. You could also see regional lymph adenopathy. So there will be enlargement of a single node or multiple contiguous nodal regions. So that would be our regional lymph adenopathy. There would also be development of flu-like symptoms within 1 to several months. So those flu-like symptoms like your fever, headache, muscle ache, malaise, They could also complain of stiff neck. So you will see those within 1 to several months. And then the client can progress to stage 2, which is the most deadly, where we'll see if the patient is not treated, you can see him going into stage 2 within 1 to 6 months. And there you will see deadly cardiac conduction defects like chest pain, palpitation. The heart rate can be very, very slow, or it could be very, very fast. So you're going to see those cardiac issues that are coming up. And then we could also see neurologic disorders. They can complain of facial paralysis, although the paralysis is not permanent, but you're going to see that in stage 2. So again, you want to be very, very conscious of these heart problems coming up in stage 2, especially when your patient has been bitten by a tick. Look out for those life-threatening cardiac problems. And in stage 3, the client may present with muscle aches. So we can see arthralgia. So there will be enlarged or inflamed joints that occur within 1 to several months after the initial infection. We could also see cognitive disorders like the patient starts becoming depressed, or you see dementia in this patient, and it may persist for several years. So again, as part of our prevention, we want to tell the clients if they are going out into wooded areas, they should cover themselves properly, and they should always check exposed areas for presence of ticks. So for this client, we'll need to give him antibiotics like your doxycycline or ceftriaxone, or even our azithromycin. So we can give them these antibiotics during the first stage, and then we can use IV penicillin G during the later stages. So these are those symptoms we talked about. Remember, we said in stage 1, you're going to see those flu-like symptoms: your headache, fatigue, fever, chills, muscle ache, sore throat. We said in stage 2, you're going to see those heart complications like a rapid or slow heart rate. You see chest pain. And then we said you could see those neurologic symptoms in this client like paralysis of the face, which is already what we've covered. And then in the third stage, you can see those hot, swollen, painful joints or arthralgias. With tuberculosis, I already talked about tuberculosis when we said MTV is in the air, is a radio station in the air. So we said MTV would require airborne precaution. T in the MTV was tuberculosis. So again, it's transmitted by the airborne droplets, and it can result to pneumonitis in the lungs. Remember, tuberculosis may lie dormant for many years, and it could also be reactivated in periods of stress, and it may spread to other parts of the body. So what are risk factors for tuberculosis? If you've been in close contact with someone who has active tuberculosis, that's a high risk. If you are immunocompromised or you use IV drugs, you abuse IV drugs, that's also another high risk. Persons who live in institutions or persons with lower socioeconomic group, those are high risk. Immigrants from countries with a high prevalence of tuberculosis like Africa, Southeast Asia, Latin America. And there's also increasing incidence in immigrant populations, in the elderly, alcoholics, persons with AIDS. As part of our assessment, what are we going to see in clients with tuberculosis? They're going to complain of this progressive fatigue, nausea, loss of appetite, and then you see them losing weight. So these are common features we see, especially with the weight loss. In females, they would complain of irregular menses. You will see low-grade fever. So again, look out for that on the NCLEX. You're going to see low-grade fevers over a period of time. There would also be night sweats. Okay, so that's another key findings you're going to see in clients with tuberculosis. So we said weight loss, low-grade fevers, night sweats. They'll be irritable, and then the common cough, which is that you see them with cough with mucopurulent sputum. They will have chest tightness and a dull, aching chest. You could even see difficulty breathing in these clients. In terms of diagnostic procedures we can use to confirm diagnosis, we can carry out skin testing and the standard recommended tuberculin test or the Mantoux test. So with this, we're going to administer 0.1 ml of PPD. PPD would be your purified protein derivative. So we're going to administer or inject 0.1 ml of PPD into the top layer of the skin. So you can see the PPD is injected into the dermis, usually of the forearm. And then we're going to measure the induration across the forearm. So again, we're not looking out for redness. We're not looking out for erythema. We're looking out for a palpable or a hardened palpation. And with our tuberculin test, a reaction is classified as positive based on the diameter of the induration in conjunction with certain patient-specific risk factors. Okay, so let's zoom into this. So again, we said our tuberculin test, our Mantoux test, we said is given intradermally in the forearm. And you want to remember that our results should be read in 48 to 72 hours. And we said we're going to measure the induration across the forearm. So we're not looking out for erythema, we're looking out for a palpable, hardened palpation. So that's what you want to see. And in reading the results, we said you want to read it in conjunction with some patient-specific risk factors. So if we have an induration that is more than 15 millimeter, is positive. So if you have 15 millimeter or greater induration, so you have a hard area under the skin, is significant, is a positive reaction for clients without certain risk factor. It does not mean that active disease is present, but it indicates exposure to tuberculosis or the presence of inactive or a dormant disease in this patient. So again, an induration of 15 millimeter or greater tells you that there's a presence of inactive disease or that this patient has been exposed to tuberculosis. That is if they don't have any risk factors. But if we have an induration of 10 millimeters to 14.9 millimeters or 10 to 15 millimeters induration, it's positive for clients at risk. So what kind of clients are we talking about? For example, recent immigrants, injection drug users, or children that are less than 4 years of old. So again, if we have an induration that is this size, between 10 to 14 millimeter, is also positive if the patient is in category 2. So again, those category 2 patients would include recent immigrants, injection drug users, and children that are less than 4 years old. If the induration is between 5 to 9 millimeters, is also positive if the patient is in a category 1. So again, those patients would include patients who have AIDS, patients who are on immunosuppressant therapy, or patients who have undergone transplant. So again, that's how you want to read your Mantoux test. So again, 15 millimeters or greater tells you, especially if the patient doesn't have any risk factor, it tells you there's been exposure to TB, and there could be the presence of inactive disease. 10 to 14.9 tells you it's positive if the patient is a recent immigrant or injection drug abuser or children that are less than 4 years. And again, 5 to 9 is positive for clients with AIDS or immunosuppressant therapy or clients who have undergone transplant. We could also carry out the multiple puncture test or the TIN test. You also want to read this in 48 to 72 hours. You're looking out for vesicle formation. If there's any vesicle formation, then it's a positive reaction. The TIN test is just a screening test only. So if we have a questionable or positive reactions, we want to verify it by carrying out a Mantoux test. So other tests we can carry out would be our sputum smear for acid-fast bacilli. We can also carry out chest X-ray, which is routinely performed on all persons with positive PPD, and it's going to help to detect old and new lesions. So again, X-rays will be used to detect old and new debug lesions, and tubercles may be seen on the lungs. And then we can carry out the quantiferon TB Gold test. As part of our plan and implementation, we want to notify the State Health Department. We want to evaluate contacts of these patients. We need to administer isoniazid prophylaxis therapy. This is a public health intervention to prevent the progression of latent tuberculosis to active tuberculosis disease, especially among people living with HIV. So again, if the patient has HIV, we'll need to administer isoniazid prophylaxis therapy. We'll also need to carry out chemotherapy to prevent development of resistant strains. Here, we're going to use 2 or 3 medications that are administered concurrently, frequently a 6 to 9 month regimen of isoniazid and rifampin. We can also use ethambutol and streptomycin. These may be used initially. Remember, we talked about placing this client in a negative pressure private room, and anybody who's going to enter the room must use a mask with a shield. We're going to place the client on isolation for 2 to 4 weeks after drug therapy is initiated, or after 3 negative sputum cultures. So again, we're going to place him on isolation for 2 to 4 weeks after drug therapy is initiated, or we've gotten 3 negative sputum cultures. And it can be sent home before this because the family is already exposed. As part of our teaching, we want to teach the client to cover their mouth and nose with tissue when they are coughing, sneezing, laughing, and they want to place the tissues in a plastic bag. They should wear masks when they're in a crowd, avoid excessive exposure to dust and silicone. You want to encourage hand washing. You want to educate them that they must take the full course of medications. They must take the full course of medications. You want to encourage to return to the clinic for sputum smears. And again, you want to encourage good nutrition, increased iron, protein, vitamin B and C. As part of our evaluation, is the client compliant with the medication regimen? Has the spread of TB been prevented? So that will be part of our goals. Let's look at hepatitis. So with hepatitis, you're going to see acute inflammation of the liver, and it's going to result in cell damage from that liver cell degeneration and necrosis. So what are we going to see in our patient with hepatitis? So there's going to be that obvious right upper quadrant pain and tenderness. There's going to be pain in the right side of the abdomen. So that's one key finding, to look out for right upper quadrant pain and tenderness. Again, we're going to see those GI symptoms like our nausea and vomiting. We're going to see anorexia, and there would also be weight loss. The client is going to have fever, there will be chills. You're going to see jaundice or that yellow sclera in your patient. You could also see a tea-colored urine, or the urine will be dark-colored. If you look at the stool also, it may be pale, or you will notice it's also clay-colored. We'll also see hives or pruritus. Remember, this pruritus is going to be as a result of accumulation of bile salts under the skin. The patient will tell you of a history of potential exposure to hepatitis. And if we do our tests, our liver function studies, for example, your ALT will be elevated, our AST, our alkaline phosphatase, even our bilirubin, they would all be elevated. Our PT will also be prolonged. And then we'll see that there will be antibodies to specific virus. So we'll see an anti-hepatitis A virus, for example, is going to be seen in this patient. Okay, as part of our diagnosis, we said you're going to see that presence of specific antibody or antigen in the client's serum. Now let's look at hepatitis A. So again, one way I used to remember this is that I know that there's hepatitis A, B, C, D, and E. But again, I can group A and E together because they are vowels. And I always remember that hepatitis with a vowel, A is a vowel, E is a vowel. So hepatitis with a vowel comes from the vowel. So that tells me that there's the mode of transmission would be fecal oral route. So that would be the fecal oral route because it's coming from the bowel. So with fecal oral transmission, what we see is that the disease is transmitted maybe through the feces of an infected individual to the mouth of a susceptible individual. And this transmission can occur through poor sanitation, leading to exposure through various routes like food. So if there's poor sanitation, the food or even the food handlers can be contaminated. The water can also get contaminated, or even shellfish in that water can get contaminated, or even through oral anal sexual activity. Okay, so oral, so when your mouth goes to the anus during sexual activity, that's also how our hepatitis A can be transmitted. So again, as part of our nursing consideration, we want to improve sanitation in these clients. We want to improve sanitation because we said food handlers can be contaminated. So you want to remember that it survives on hands. As part of our diagnosis test would include, we want to culture the stool and also look at the serum before onset of the disease. And just like we have here, you would see that our hepatitis A has a vaccine. So that will be part of our nursing consideration. And we want to treat with gamma globulin early post-exposure. So again, that will be for hepatitis A. So again, remember we said hepatitis A is a vowel. Hepatitis with a vowel comes from the bowel. It's a fecal oral route. We said it has a vaccine. We said it's as a result of transmission from the feces to the mouth. So we said it could occur through poor sanitation from food handlers or the food itself or from the water or from oral anal sexual activity. We said it survives on hands. So we want to improve our sanitation. We want to give vaccines. And in the early post-exposure period, we want to treat with gamma globulin. With hepatitis B, okay, so with hepatitis B, B tells me B for body fluids. So I know when I remember B for body fluid, I remember it could be transmitted through body fluids like your blood. So with blood, maybe from transfusion of infected blood or blood products, or even through parenteral drug abuse, through infected needle, or even during hemodialysis. So that tells me, that reminds me of how it could be transmitted through the blood. Again, it could also have sexual transmission through semen. Again, it could also be transmitted through the saliva and even through maternal fetal routes. Okay, so body fluids. So that's one way to remember it. So with hepatitis B, what should be our nursing consideration? Okay, so that will be our diagnostic tests. So you're looking out for hepatitis B, surface antigen. Treatment would be to give hepatitis B immune globulin post-exposure. So if you know you've been exposed to hepatitis B virus and you are not sure you've been vaccinated, an injection of hepatitis B immunoglobulin given within 12 hours of exposure to the virus may help protect you from getting sick with hepatitis B post-exposure. And again, because this treatment only provides short-term protection, you also should get the hepatitis B vaccine. For example, your Heptavax B or Recombivax HB. So you want to get the vaccine at the same time if you've never received it. We could also give interferon alpha 2B to fight the infection. We can give lamivudine, which is our antiviral medication. And again, we're looking out for complications, those long-term complications like cirrhosis or liver cancer. With hepatitis C, C tells us circulation. So again, I know it has to do with transmission through blood, bodily fluids, semen. So again, contact with blood and body fluids like semen during unprotected sex, even mother-to-child transmission, or even needle stick injury, or maybe IV drug users sharing needles. With hepatitis D, D reminds me, if I spell blood, I have D at the end. So that tells me blood. I remember blood from the D if I spell blood. So again, a D is for blood. At the end, blood ends with D. So that tells me the transmission is through blood. What else do I need to know with hepatitis D? I know that it occurs among people who are infected with the hepatitis B virus. So it co-infects. So just like it's written here, it co-infects or it super-infects with hepatitis B virus. So anytime I see hepatitis B virus, I'm already looking out for hepatitis D virus in this patient. And then we'll go back to hepatitis E again. Remember we said E is a vowel, so it also means the transmission is going to be fecal oral transmission. Again, hepatitis E resembles hepatitis A because they are transmitted through the same route. It doesn't become chronic. It's usually seen in young adults. It's also seen in travelers from Asia, Africa, Mexico. So what's our plan for the clients with hepatitis? We want to encourage frequent rest periods. If the client is diagnosed with hepatitis A, is incontinent, or they are using diapers, we want to initiate contact precautions in addition to standard precautions. Remember, we said you're going to have the hepatitis in the feces and then it's transmitted to the mouth. So again, if they're incontinent, you want to stay clear of those products and initiate contact precautions in addition to standard precautions. We also need to encourage diets that is low in fat, high in calories, carbohydrates, and protein. Please no alcoholic beverages for this client. Remember, we talked about that they would have those pruritus. So we'll need to use calamine lotion. We need to encourage them to keep their nails short so that they don't injure themselves while they are scratching. And we also need to give them antihistamines. Part of the medication we'll need to give this client will be vitamin K. Remember, in these patients with hepatitis, most times you see vitamin K deficiency. And if you remember that vitamin K is essential for the synthesis of coagulation factors, that's why we give them this vitamin K, because it's going to help to improve the coagulation function and also decrease bleeding risks in these patients, especially in case they progress to liver failure. We'd also need to administer antiviral drugs like our interferon and our lamivudine. We'd also need to give post-exposure hepatitis B vaccine. As part of our teaching, we want to teach the client and the family to avoid alcohol and potentially hepatotoxic prescriptions, even over-the-counter medications, particularly aspirin. They need to avoid acetaminophen and even sedatives. They want to balance rest and activity periods. Remember, we said they're always going to be fatigued. We want to teach them techniques to prevent spread of the disease. We also want to remind them that they cannot donate blood. They cannot donate blood. And then they want to note and report recurrence of signs and symptoms to the healthcare provider. Let's look at sexually transmitted infections like our AIDS. So AIDS will be your acquired immunodeficiency syndrome, a syndrome that is distinguished by serious deficits in cellular immune function that is associated with positive HIV virus. Again, what are you going to see in these clients? Clinically, you're going to see opportunistic infections like your pneumocystis gyroviri pneumonia. We're also going to see Candida albicans and even cytomegalovirus. We'll also see enteric pathogens, and then we can also see malignancies. The most common would be our Kaposi sarcoma. So you're looking out for these opportunistic infections and these set of clinical presentations in a client with AIDS. So what are high-risk groups for AIDS? Homosexual or bisexual men, especially with multiple partners, intravenous drug users, hemophiliacs, especially through contaminated blood products. So what's hemophilia again? That disorder in which blood doesn't clot normally. Clients who received blood transfusions prior to 1985, they had high risk. Heterosexual partners of infected persons, children of infected women in utero or at birth. Again, transmission is going to be through contaminated blood or body fluid, sharing IV drug needles, sexual contact, transplacental, and possibly through breast milk. Again, you also want to know that time from exposure to symptom manifestations may be prolonged up to 10 to 12 years. So let's look at those opportunistic infections. We said there are those infections that occur more frequently and are more severe in people with weakened immune system, including people with HIV. And many opportunistic infections are considered AIDS-defining conditions. So once you see them, you're already suspecting AIDS. And one of them would be your Pneumocystis gyroviri pneumonia, or what we refer to as P. carinii. So if your client has Pneumocystis gyroviri pneumonia, you're going to see gradual worsening chest tightness and shortness of breath. There will be persistent dry, non-productive cough, rales, difficulty breathing, tachypnea. They would have low-grade or high fevers. And there will be progressive, so it's getting worse, progressive hypoxemia and cyanosis. So that's what it would look like on a chest x-ray. You would also see Candida albicans, stomatitis, or esophagitis. So in this condition, there's going to be changes in taste sensation. They would complain of difficulty swallowing. They would have this retrosternal pain, and the obvious clinical presentation of that white exudate and inflammation of the mouth and the back of the throat. So this is what's going to look out. So you're going to see those white exudate and inflammation of the mouth and the back of the throat. Other opportunistic infection would be our Cryptococcus neoformans or C. neoformans, which is a severe debilitating meningitis. That's why you're going to see that stiff neck. So that's one common sign. But in the earlier period, you're going to see fever, headache, there could be blurred vision, those GIT symptoms like your nausea and vomiting. And then we'll start seeing those stiff neck or neck pain. We would also see mental status changes. There could be seizures. We could also see cytomegalovirus or CMV. CMV is a significant factor in morbidity and mortality in these clients. And we're going to see fever, malaise, weight loss, there'll be fatigue. You would notice the lymph nodes will be abnormal in size or consistency. We would also see retinochoroiditis, which is characterized by inflammation and hemorrhage. There will be visual impairment. You would also see inflammation of the colon. You will see inflammation of the brain, often due to this infection. You would also see inflammation of the lung tissue. So that will be colitis, encephalitis, pneumonitis. And then there will be adrenalitis, which is inflammation of one or both of the adrenal glands, which can lead to an insufficiency of adrenaline or noradrenaline. You could also see hepatitis and disseminated infection. Another opportunistic infection would be our Kaposi sarcoma, which is most common malignancy you see in these patients. You will see this malignancy could be varied in size. It's usually flat, has this purplish brown color. It's non-painful, it doesn't pain, it doesn't itch. So you will see this varied size palpable lesion, purplish brown. So you can see it's flat, it's not painful, it doesn't itch. but again, it's raised, so it's palpable. So you see these lesions occurring on any part of the body, and it's most commonly seen on the skin. It could be diagnosed by biopsy, and it could be treated with local radiation or chemotherapy. As part of our diagnostics test, we can carry out enzyme-linked immunosorbent assay or your ELISA, or we can carry out Western blot assay. We can do indirect immunofluorescent assay or a viral load testing, CD4 to CD8 ratio. We can do antigen assays. We can do radio immunoprecipitation assays or our CBC, which can reveal leukopenia with serious lymphopenia, anemia, thrombocytopenia. Let's look at our nursing care for these clients. So again, there's no effective cure. We can give antiviral medications like our zidovudine, our cyclovir. These are used to slow progression of the symptoms. But again, treatment is specific to the presenting condition. So if the client presents with Kaposi sarcoma, we can use local radiation as a palliative measure. We can use single agent or combination chemotherapy. For fungal infections, we can use nystatin, swish and swallow, clotrimazole, oral solution, and also use amphotericin B with or without flucytosine. For viral infections, like we mentioned earlier, we could give our cyclovir or our ganciclovir. With these clients, we need to carry out contact precautions in addition to standard precautions. Part of our nutrition would be to give high protein, high calorie diets. We'll need to carry out symptomatic relief, just those comfort measures. And we also need to maintain confidentiality with this client. So you want to provide support with client and family coping. You want to identify their support system. You also want to minimize social isolation in these clients. We don't need to carry out any isolation precautions when we are entering the room to talk to the client or to take vital signs or to administer oral medication. So again, remember, no isolation precautions are needed to enter the room to talk to the client, to take vital signs, to administer oral medication. And again, you also want to encourage verbalization of feelings. So with clients, family and discharge teaching, you want to teach them behaviors to prevent transmission. So like safe sex, not sharing toothbrushes, razors, and other potentially blood contaminated objects. You want to teach them measures to prevent infections like good nutrition, good hygiene, rest, skin and mouth care. They should avoid crowds. And also as part of preventive measures, you want to teach them to avoid IV drug use, no needle sharing, precautions regarding sexual patterns, so sex education, use of condom, avoiding multiple partners. And again, you want to use standard precaution. As part of disease susceptibility, you want to implement infection control measures, hand washing on entering and leaving room, monitor for oral infections and meningitis, and want to give antibiotic as ordered. For those respiratory distress, you want to monitor the client's vital signs, breath sounds, give bronchodilators and antibiotics as ordered, suction and maintain oxygen as ordered, monitor for symptoms of secondary infections. And as part of those anxiety and depressions, you want to use tact and sensitivity in gathering personal data, encourage expression of feeling, respect the client's own limits and ability to discuss the problem. With the anorexia and the diarrhea, you want to monitor the client's weight, encourage nutritional supplements, and you also want to assess hydration in this client.